patients are in the early stages of myelofibrosis, are there medications or treatment options that help kind of keep the blood cell counts at the normal level or lower them?
Yeah, great question. So, patients who are in the early stages of myelofibrosis, and there's a few different names that can be given to that. Sometimes we call it the cellular phase of myelofibrosis. Other times we call it prefibrotic myelofibrosis. Both names really highlight the fact that early myelofibrosis patients tend to have high blood counts because the bone marrow has not yet had so much scarring that the blood counts are starting to drop.
Mm.
Um, it's very unclear whether reducing the blood counts in patients with myelofibrosis impacts the risk of the disease progressing or kind of impacts the other issues related with myelofibrosis, such as increased spleen, et cetera. A medicine that's commonly used to reduce the blood counts is one called hydroxyurea. And again, to highlight, it's unclear whether reducing blood counts in someone with early stage myelofibrosis is going to appreciably change the likelihood of the disease progressing or starting to behave in a more aggressive fashion or things like that. Sometimes patients do feel better when their blood counts are closer to normal. So sometimes hydroxyurea can make patients feel better from a symptom burden as the blood counts go down. There are also clinical trials ongoing looking at a drug class called interferon in early myelofibrosis, really with the intent of kind of looking at does using interferon for early myelofibrosis reduce the likelihood of the myelofibrosis progressing to that kind of overt fibrotic or scarred down stage of disease.
Dr. Patel, can you walk us through how myelofibrosis is really managed and what treatments options are really available at this moment?
Yeah, absolutely. So in this day and age, the main kind of set of approved medications we have for myelofibrosis are called JAK inhibitors. And we have four approved JAK inhibitors. There's ruxolitinib, fedratinib, pacritinib, and momelotinib. All of these JAK inhibitors really were approved with the endpoints being focused on shrinking down a patient's spleen and making patients feel better based on their symptom score. With that in mind, the patients that benefit the most from JAK inhibitors that have myelofibrosis are those that have a large spleen and or significant symptoms. I think it's important to note that the JAK inhibitors are not a cure for myelofibrosis, unfortunately. They can help people feel better. They can shrink down the spleen. Perhaps, we don't know for sure, but perhaps there's some benefit in terms of delaying disease progression with JAK inhibitors, although we still need more data to kind of help us really tease that piece out. But these are not a cure. The only way we know how to cure myelofibrosis is with what's called a stem cell transplant. And stem cell transplant has its own significant risks associated with it. So, when we think about the management of myelofibrosis, one of the major things we think about in terms of will a patient benefit from a stem cell transplant or not is an application of those risk scores. So, in general, patients with intermediate or high risk myelofibrosis are who benefit from a transplant. For patients with low risk myelofibrosis, oftentimes their disease can be monitored and they'll do just as well without a transplant. So there's a lot of work being done in the context of clinical trials to see if we can add drugs to JAK inhibitors to better improve symptoms. There are now even some studies that are looking at, do we have drugs available that will help patients live longer than the current standard? But our current mainstay of treatment is JAK inhibitors and then consideration for stem cell transplant in appropriate patients.
Great. And when we think of goals of treatment, what are the main treatment goals for myelofibrosis? Is it, quality of life, delaying progression, or avoiding progression, just keeping their blood count stable? Can you walk us through really what some treatment goals should be for patients that are living through with myelofibrosis?
Yeah, I think ideally the things we would want to achieve with any treatment for myelofibrosis is reduction in spleen, improvement in symptoms. If someone's blood counts are low, that they either stay stable or ideally get better, and that we delay progression to what's called the blast phase of disease, where someone's myelofibrosis starts to behave more like an acute leukemia, which is a more aggressive blood cancer. Now, Currently, we have medications available to us that can shrink the spleen, address symptoms. Some of the JAK inhibitors we have are better than others at keeping blood counts stable or maybe even slightly improving blood counts.
Mhm.
And as I mentioned earlier, we don't really know for sure if JAK inhibitors truly can impact the risk of myelofibrosis progressing to acute leukemia. So, we have these ideal goals of treatment. Currently, I would say our treatments available to us can't always check off all of those goals of treatment when it comes to the boxes that we want to check off. And really, again, coming back to the only way we think of being able to potentially address all four boxes in someone with higher risk myelofibrosis is with a stem cell transplant. Now, I think it's important to say that stem cell transplant is not something that is of benefit to everyone. Transplant has its own very significant risks with it. Um, so, with that in mind, really a nuanced conversation and discussion has to be had about, does the way my myelofibrosis is behaving warrant a transplant? So, is it in that low risk versus intermediate or high risk bucket? And is a patient well enough to get through a transplant, recover from a transplant, and ultimately be able to reap the benefits of a transplant with potential cure of their disease?
Excellent. What are some of the factors that really determine transplant eligibility and really the timing?
Yeah, so I think about a few things. So I think about the disease itself, so someone's myelofibrosis. So there, really what we're asking is, are there features of the myelofibrosis that make us say, without transplant, a patient is very likely to get sick and potentially die from their myelofibrosis over the next 3 to 5 years? Sometimes our risk scores don't fully capture how severe someone's myelofibrosis is. For example, someone with low risk myelofibrosis who's requiring blood transfusions very frequently, that may be someone that could still benefit from a transplant. But in general, these risk scores help us kind of identify the intermediate and high risk patients that could benefit from transplant. The next is the patient themselves. So a variety of factors go into characterizing, is a patient someone that we think would benefit from a transplant and do well with transplant. So those things can be age, they can be other medical conditions like heart disease, lung disease, a prior history of cancer. So they're what we call kind of comorbidity scores, where you kind of get a sense of how well is someone going to do with a transplant or not based on the medical conditions they have. And then the third kind of thing we think about is donors. So, is a appropriate donor identified for a patient to undergo a transplant? And in this day and age, thankfully, we are able to safely and effectively do transplants even for patients that don't have fully matched donors. We can do what are called mismatched transplants, or transplants with half matches, so what we call haplo transplants. So really, our pool of potential donors has thankfully gotten a lot bigger over the last several years. And then the fourth and final thing is disease control going into transplant. So, in general, the better someone's myelofibrosis is controlled going into transplant, the more likely it is that transplant is going to cure the disease. So, when I say disease control, what I mean is trying to get the spleen as small as possible going into transplant, and trying to move to transplant before the myelofibrosis is starting to behave like an acute leukemia. So going to transplant in what we call the chronic phase of someone's myelofibrosis, as opposed to more of this blast phase or leukemic phase.
Excellent. Thank you. For those that are told, kind of the watch and wait, and just doing the watchful monitoring, are there things that they can do, to help their health, whether it's diet or exercise, or just what other factors can they do as they're, in that treatment phase of watch and wait?
Yeah, I would say the most prominent symptoms I've noted in my patients that we are kind of engaging in watch and wait is that they still have fatigue related to their myelofibrosis. And in general, we know that for cancer associated fatigue, one of the best things you can do is try to engage in 15 to 20 minutes of kind of brisk exercise a day. So really kind of being able to get the body moving, and it actually helps to combat the fatigue. For patients, I think that are unable to do that, sometimes they've found that the fatigue feeds into more fatigue, feeds into more fatigue, and they have a hard time kind of breaking that cycle. There is not a clear cut kind of diet that I kind of endorse for my patients with myelofibrosis, although there's maybe some early evidence to say that diets like the Mediterranean diet may help from an anti-inflammatory standpoint. But in general, I think my dietary recommendations are ones that we would really give to anyone when thinking about healthy eating, kind of a well-balanced diet, trying to minimize the number of processed foods that you're eating, trying to make sure that you're getting kind of servings from the various food groups. But if someone is really kind of looking to hone in on a specific diet and willing to try it, oftentimes I would say if they want to try something like a Mediterranean diet, recognizing that the data for it is not super strong, but some data there, that's something that can certainly be worth trying.
Great. And how can patients really partner with their care team to really stay engaged in this decision making as those treatment options are determined and being discussed?
Yeah, I mean, I think it's always important for a patient and a physician to think about why we're doing what we're doing. And I actually think it's important to do that at every visit. So oftentimes for patients that are in watch and wait or active surveillance, sometimes we kind of get into a rhythm of just expecting that to be the thing that we're going to keep doing at every visit. But I think each visit is a time point for us to reassess, both patient and care team, to reassess, are we doing the right thing by continuing with active surveillance? If yes, why? And if no, what treatment should we be thinking about? And I think that can actually be applied to patients that are on JAK inhibitors as well. Uh, you know, just because someone is on a JAK inhibitor does not mean that is the drug that they need to stay on indefinitely. There are times and circumstances where thinking about switching to a different JAK inhibitor, thinking about a stem cell transplant, thinking about a clinical trial is very important. So I think the most important kind of question I like to always think about when seeing a patient, and oftentimes patients will ask me is kind of the why are we doing what we're doing, and do we need to change what we're doing?